Hi, I am Dr. Sipho from the Academy for Quality Healthcare. Today I'm going to present a topic on male urethritis syndrome, which is a subtopic of sexually transmitted infections. This topic is made possible by the Academy for Quality Healthcare, which exists to enable improvement and safe care across the continuum of healthcare in South Africa. Our vision is to see a quality healthcare system that is free from harm. Our focus today is on male urethritis syndrome and mainly based on the South African STI guidelines. Some of the key changes in South African STI guidelines include that Ceftriaxone is no longer used in South Africa. We now prefer and recommend Ceftriaxone as an intramuscular injection. Doxycycline is no longer part of the guidelines unless for patients who have penicillin allergy. The recommended drug is now azithromycin. Ciprofloxacin is no longer part of the guidelines. Ceftriaxone IM together with benzyl penicillin are to be dissolved in 1% lidocaine without epinephrine or adrenaline. This is to assist with the commonest complaint from patients, which is pain after the injection. The rationale to switch to Ceftriaxone IM one is that it improves adherence because it is a single IM dose. It is quite effective against resistant strains for gonococcal, especially if strains are resistant to cefixime and ciprofloxacin. It is quite efficacious. And the previous barrier was that patients would complain of pain at the injection site. We are now recommending that it is combined or diluted with lidocaine 1% without epinephrine. The rationale to introduce azithromycin, it is because of it is quite an effective drug against chlamydia. It improves adherence because it is also given as a single dose, and if or when given in combination, we do get a delay in the emergence of resistance. So in terms of male urethritis syndrome, we have this South African algorithm. Whenever you have a male who presents with a urethral discharge or painful urination, we have to take full history, including sexual orientation, and provide a physical exam. As part of the examination, we have to assess whether there is a visible discharge. If there is no discharge, we have to ask the patient to milk the urethra to see if some discharge would be visible. It is also very important that partners are traced and partner sexual history is taken, and also we emphasize HIV testing for both the patient and their partner. If there is a discharge, the treatment is a dual therapy of ceftriaxone and azithromycin as single doses. The ceftriaxone would be given IMI 250 milligrams as a single dose, azithromycin oral 1 gram as a single dose. If the sexual partner also, there's a confirmation that they had vaginal discharge syndrome, it is recommended that we add metronidazole 2 grams as a single dose. These patients need to be followed up within or after 7 days for symptoms. If the discharge is still there after 7 days, we have to suspect that there is some treatment failure from the ceftriaxone 250 milligrams. The treatment would include a higher dose of ceftriaxone, which is 1 gram IMI as a single dose. The azithromycin dose would also be doubled to 2 grams orally, and this time around the metronidazole would also be given orally 2 grams as a single dose, especially if it was not given initially. Should a patient fail to respond to this treatment, it is recommended that they are referred for a gentamicin dose. this would probably be available at a hospital given as a 240 milligram single dose IMI. Where the patient has severe allergy, we have to omit the ceftriaxone, but then increase the dose of azithromycin given together with gentamicin and metronidazole accordingly. It's very important that for the ceftriaxone we have to dissolve it with 1% lidocaine to minimize the local pain. Some of the specific changes is that it's very important to ask about the sexual orientation, okay, because MSMs are more likely to develop drug-resistant cases. We have to trace partners and ensure that they are also treated if they have STIs, and also HIV testing is provided. Only patients with a discharge will be treated. So if a patient has dysuria only, we have to consider other things. If there's dysuria with a discharge, we have to treat according to the MUS guidelines. It's where there is no discharge, we still consider treating, especially if the partner of the client is known to be having vaginal discharge syndrome or has male urethritis syndrome. We would have to treat the patient accordingly. Okay. The treatment of male urethritis syndrome has changed from cefixime to endoxycycline to ceftriaxone, azithromycin, and an additional metronidazole for patients where the sexual partner has vaginal discharge syndrome. Where there is allergy to ceftriaxone, we need to increase the dose of azithromycin to 2 grams orally. We no longer give ciprofloxacin as part of treatment for MUS. Okay. If the urethral discharge persists after 7 days, we suspect that there's treatment failure. Then we have to increase the dose of ceftriaxone from 250 milligrams to 1 gram as a single dose. This will be dissolved in 3.6 mils of 1% lidocaine without epinephrine. The azithromycin dose is doubled from 1 gram to 2 grams. The metronidazole is given as 2 grams as a single dose, only if it was not given with the initial treatment. Where there is an allergy, we omit ceftriaxone and refer the patient for gentamicin and azithromycin. All patients with ceftriaxone treatment failure have to be referred, especially those who do not respond within 7 days of starting treatment. Putting this information into practice, just a basic case scenario. Sipho is a 24-year-old male who comes to your clinic complaining of dysuria or painful urination. The questions are, what do you need to ask as part of your history? What would be part of your physical exam or any tests that you would like to do? If you follow the algorithm, we have to take proper history of the symptoms, around the pain. When did the pain start? Is it only limited to the penis, or does it include the testes, the abdomen? Is there any discharge? Are there any lymph nodes? Is there any swelling? What kind of discharge is this? Does the patient have any ulcers? So if there is a pain in urination with or without a discharge from the patient's complaints, you have to consider male urethritis syndrome. We have to ask about the sexual orientation. We have to examine for a discharge. If none is visible, we have to ask the patient to milk the urethra. We have to screen for other STIs and also provide an HIV test for our patient. So, continuing with the case, Sipho tells us that he has experienced dysuria in a discharge for the past 2 days. He does not have any other signs and symptoms. He is HIV positive. He has had both male and female sexual partners in the past 3 months. As far as he's aware, none of his partners has had any STI recently and no drug allergies. On examination, you observe the discharge. There is no evidence of ulcers, rashes, scrotal swelling, or boo-boos. Okay. So how do we treat Sipho? Okay. If Sipho had not had a discharge, what other circumstances would you still treat? So where someone you still suspect MUS but there's no discharge, especially for patients who men who sleep with men, where there is a history that the partner has either MUS or a VDS, we would have to provide a presumptive diagnosis of MUS, and that needs to be treated. So we would still treat with Ceftriaxone 250 milligrams as a single dose, dissolved in 0.9 mils of lidocaine, 1% lidocaine, with azithromycin 1 gram as a single dose. Okay, this is because since he does not have a partner, from his history he said none of his sexual partners had reported any STI. There is therefore no indication to add metronidazole to his regimen. He goes home, he takes his treatment for 7 days, he comes back with persistent discharge. What do you suspect? 2 things. Either he's poorly adhering, 2, he's got a resistant bug, 3, he just has a treatment failure, Ceftriaxone treatment failure. What aspect of Sipho's history increases your suspicion of potential treatment resistance? Well, the key one is that he is a man that sleeps with men with a very high risk of having a resistant gonococcal bug. So that is probably so what we do test is probably to retreat him for another 7 days, consider referring him for gentamicin, and the current regimen we would have to give the same drugs but higher doses. That would include increasing the Ceftriaxone from 250 milligrams to 1 gram, the azithromycin from 1 gram to 2 grams, the metronidazole 2 grams as a single dose only if it was not given in the initial phase, and probably consider referring him for a gentamicin dose probably at a hospital. Okay. So HIV, STIs, TB, these 3 diseases are always integrated. We have to provide integrated care. And as part of the integrated care, it means all patients ages 15 to 49 should be screened for STIs regardless of how they present, because we are probably talking to a sexual active group of people. These are the 3 screening questions. Do you have any genital discharge? Do you have any genital ulcers? Has or have your partners been treated for an STI in the last 8 weeks? If a client or patient says yes to any of these 3 questions, you should probably investigate further and assess the need for treatment. Also remember the 7 C's. The first one is that whenever you diagnose a patient with an STI, always provide counseling, education, including HIV testing. We have to promote condoms and educate around how to use condoms. We have to support and ensure that there's compliance to STI treatment and any other treatment they might be taking. We have to have an interest in the partner, because the partner is likely to also have an STI and they need to be treated. If it's a male, we have to offer a circumcision. If it's a female, we have to offer cervical cancer screening. And again, for females, contraception and conception counseling is very, very crucial and important. Additionally, consider post-exposure prophylaxis. especially for those where the other partner might be suspected to be high risk for HIV. We have to consider HPV vaccination, and if it's a pregnant mom, we must consider screening for other sexually transmitted illness, including syphilis and HIV screening. The take-home message: screen for STIs at every visit and ensure that we have capability of providing appropriate treatment. Thank you very much for your time, and I hope this presentation was worth your time. We look forward to engaging with you on our online platform. Thank you.